Okay, good evening, dear students. So today we are going to talk about how you will attempt the OSCE session, which consists of counseling sessions. So as you all know, the message which has come from the DNB board for all the exam going students in December says that you will be having the exam only on one day, not like 2 days, how we used to have during non-COVID times. It will be like the virtual exam during COVID times. Just have a look at that one more time. Does anybody have any confirmed information about this? So if it is like the earlier times, like how virtual exams were there during COVID times, then you will be having counseling sessions which are displayed, and you will have to write the answer in 5 minutes. There will be nobody sitting in front of you. So you will have to write the counseling session in 5 minutes. In counseling sessions, when you have to write, it becomes important that you write as much as you know, but write the important points as a priority. So what I've done is, since you know these topics already, I have just put the important points which you should not miss. The other points here and there will remain the same for most of the other counseling sessions. So as you know, mostly these are the things which you will be talking about. Either if you have to talk to the examiner or you have to write these down. So mostly it starts with introduce yourself. If you are given a symptom, then you need not talk about the disease or the different diseases which cause the symptom. But if you are given a disease, something which is already proven, then you have to talk about what the disease is about and the etiology of the disease. If there is a symptom, then you will have to write about what investigations you will do to prove or to reach a diagnosis. If the diagnosis is given or something like suspicion of like that is given, then you will have to write the investigations. And if the diagnosis requires follow-up investigations, then you have to mention them over here. You have to talk about etiology, you allay anxiety, you give a general prognosis. So don't talk about too much of the future prognosis, but make a passing mention. Right, very, very important to mention about follow-up and red flags because that carries a lot of marks. Always explain about how they can get help. Explain about presence of social worker. Do not forget about mentioning future pregnancies if you have already the diagnosis given to you. And if you have the time, then mention about if there is anything specific related to nutrition or vaccination in depending upon what the OSCE is. And in the end, of course, you will ask the patient or the parent if they have any questions. So this is usually nothing more than these you can talk about in those 5 minutes. So let's start with the first question. So this says, counsel a mother whose child has been recently diagnosed as thalassemia major. So I don't know why students, but I'm not able to see y'all at all. There is something with my Zoom. I'm only able to see this slide. So if there's anything, please stop me in between. I will not know if you all want to say anything. So counsel a mother whose child has been recently diagnosed as thalassemia major. Now, as you know, this diagnosis has already been given. Now, sometimes it may be that the diagnosis which is given is not the terminology which is followed now. So you know that, right? There is nothing, we don't call it as thalassemia major, minor, intermediate anymore. We just call it as transfusion dependent anemia or transfusion dependent thalassemia and not non-transfusion dependent thalassemia. So make it a point to mention this, but don't let it be as the main point of discussion. You can say thalassemia major, but of course make it a point to mention that your child has that type of thalassemia, which we now call as transfusion dependent anemia. Okay. So here you have to talk about the etiology. So you can say that this is an inherited single gene disorder. If you have the time, you can mention the second point, which I've mentioned. If you have to write, I think it is a good idea to write it because it tells the examiner that you know exactly how thalassemia is inherited if each parent has the carrier gene or if both the parents have the carrier gene. The next thing is about thalassemia is you need to mention up to the parents that even if the diagnosis has been made, this child has to undergo certain genetic testing, which also needs to be done in the parents, so that when the parents plan the future pregnancy, the same genetic defect can be tested by amniocentesis or chorioambulis biopsy in the baby. It is important that you explain about what kind of transfusions will be given. You will have to talk here that when this child continues to take multiple transfusions, he will require chelation because there is possibility of deposition of iron in different organs. You have to mention about different forms of therapy, but don't go into details. So you can say that only certain genetic disorders which are in thalassemia can be treated with hydroxyurea if you want to increase the duration between transfusions. And of course, you can mention the curative form of therapy. So what I've done is these are the points which should be there in your counseling. Now, let's just go through each of or some of the points which you already know just as a revision for y'all. So y'all will know what to say to the parent actually. So first, can somebody tell me how do you describe how to give transfusions to a patient with thalassemia? Is there any way you can describe what is the way to give transfusion? Can somebody try? How much amount of blood will you give at a time? Anyone?
Around 15 ml per kg.
Yes.
Every
Of what?
of PRBC which are ABO, RH, and matched for other antigens, including the KL antigens, and they are to be given at a frequency of around 2 to 5 weeks, 2 to 4 weeks interval.
So there are many things that you have to say.
And leukodepleted. They should be
very
leukodepleted.
Good, very good.
And
yes.
And always pre-tested for basic, if possible, for CMV and HIV.
Correct. So you have to say that about 15 to 20 ml per kg of group 10 cross-matched packed red cells, which are leukodepleted, which are pre-tested for hepatitis B, HIV, and hepatitis C at least, which are given to a patient to maintain the pre-transfusion hemoglobin between 9.5 to 10. All right. So these are the different things that you need to mention when you are asked about what kind of transfusion to give to this patient. Now, when will you add chelation at the serum ferritin level of 1,000 or more?
1,000.
Correct. So you will start at that time, you will start with chelation. So what is your target to maintain the ferritin below 1,000? Correct. You will have to keep monitoring the ferritin levels frequently once the child is on regular transfusions. Even if the ferritin levels fall below 500, you do not need to stop the chelation. You can decrease the dose. When the child remains on a high ferritin in spite of regular chelation, it is also required to do other investigations to see if there are chances of iron accumulation in other organs like the pancreas or the liver or the heart. So there are other tests like MRI, T2 star, etc., which can be done. They can be done even if the ferritin levels have not yet started increasing. You can still do them at regular intervals. There are studies which suggest that there may be no correlation between the ferritin levels and the iron deposition. So MRI T2 star will let you know much in advance if there is iron deposition in these vital organs. Different kinds of chelators are available. You know about them already. So deferasidox, deferrioxamine, and deferiprone. You need to know the doses, the route of administration, and the common side effects of all three of these. This is important for you, especially if you're giving a case presentation which is on thalassemia, that time you will be asked about these. It's not important in the counseling session. This is just for your knowledge, but you will be asked about what are the different chelators that you can use in a case presentation when you are giving your viva. So this is all that I think, more than, of course, transfusion, you know everything about. And the most important thing about thalassemia is how do you give the transfusion? How often do you give the transfusion to maintain the pre-transfusion hemoglobin at how much? And what are the different chelators available? When do you start chelation and how do you monitor? Correct? So these are the different things that you will have to talk about when you are having a question like this. Counsel a mother whose child has been recently diagnosed as thalassemia major. Now coming to the second question. So this is counsel a mother whose 2-year-old has a speech delay. So here, as I said before, you are given a symptom, not a diagnosis. So first you need to tell the parent what is normal. You have to tell them that we will have to look for other milestones and take a detailed history, because you are not going to ask any questions to the examiner here that, can you tell me if this 2-year-old is doing this. You cannot do that, or you cannot say that I want to examine, because there is only a screen in front of you. So you have to make it a point to tell the examiner that you will be doing these things. You have to tell them that there are different causes. So write about the etiology of speech delay in general. You can mention about the investigations, that since your child seems to have a speech delay, we will be doing a hearing test in the form of BERA. We will be doing MCHAT, which is a screening test for autism. You will have to mention if at any point there is requirement for a specialist to see. So here, for example, you can say that you might have a developmental pediatrician, a speech therapist, physiotherapist, occupational therapist, depending upon what the symptom is given to you. So any specialist that needs to see the child. You have to say what kind of treatment will be offered. So you can say once the diagnosis is made, we will ascertain what all therapies your child needs. You can explain to the parents here only that even after starting therapy, it is important that we do a regular follow-up to see how well your child is doing. Is the child responding to therapy or not? And of course, if there are any factors which can cause, which you can easily avoid, like avoiding screens, then you have to explain to them. And of course, you have to tell them to encourage playtime. Do not mention any controversial things. Like, for example, here you may not mention to the parents that please make sure that the child does not have exposure to multiple languages at home, because you know now that that is not supposed to be a cause for speech delay. And so these, if there is any controversy in your mind, best not to mention. This is a chart from Nelson, so you know when the child is doing what. This is related to communication and language. So what the child does. There is also something known as receptive language, means does the child understand? So at 10 months, the child responds to names, so the child is understanding. At 2 years, the child performs 2-step commands. At 2.5 years, the child performs 3-step commands. Somewhere around 18 months, the child is able to point to about 3 body parts. So these are all the receptive language that the child has. Now, what is mentioned here is more of the verbal. What does the child express? Receptive is different, expressive is different. So here we have, when do they start saying monosyllables? When do they start saying words? At what point do they combine 2 words to form sentences? When do they speak sentences which are understood by the parents, sentences which are understood by others, and things like that. So you need to know this table, and you need to tell the parent about what is expected as normal at 2 years of age or at 1 year of age, depending upon what is given to you in your question. What are the red flags for language problems? So this slide is for you. You may not write this in the exam, but this is for you to know. So if the child is not babbling, pointing, gesturing by 10 to 12 months, it's a red flag. If the child is not understanding simple commands by 18 months, he's not using any words by 18 to 21 months, he's not combining words to form sentences by 2 years, his speech is difficult for the parent to understand even by 2.5 years, his speech is difficult for others to understand by 4 years, the child tends to avoid talking situations, and any regression in the speech, all these are red flags for language problems. So you can quickly mention to the parents only related to what age the child is in your question, that since your child is not doing 1, 2, 3, 4, we think that this is red flag, and therefore we need to evaluate your child further and do investigations to find out why the speech delay is happening. So explaining about red flags, or either at least using this word red flags, becomes very important, especially if you have a symptom in your question. Now, counsel a mother, a breastfeeding mother before joining work. Now, I want one of you to please try doing this. You can use the points which are given here on the screen. In 5 minutes, will you be able to talk about, because this is very basic, there is nothing here for me to teach you. Anyone? How will you counsel a breastfeeding mother before she joins work?
First, we would like to tell the importance of breastfeeding, the nutrition part, and the advantages of breastfeeding. Like it is low cost feeding for the baby. The advantage for health, advantage for bonding with the mother, as well as nutritional advantage of the breastfeed is in contrary to that, the options which the mother can do for going to work, the methods of expressing the breast milk and storing the breast milk, and to feed that expressed milk by vati spoon feeding and not by bottle feeding, and to teach the same technique to other family members who will be at home while the mother has gone for work. Uh, Also explain the mother regarding the storage of the expressed breast milk, like at room temperature, it can be stored for about 1 to 2 hours. If refrigerated, it can be stored for about 12 hours. And if at all it is frozen, and if it is after taking out of the fridge, it should not be heated, and it should be cooled at the room temperature. Also, the mother should be explained about the weaning out the exclusively breastfed till 6 months, and after that weaning should be explained. For weaning, the new food item should be added gradually, one food item at a time, and it should be continued for 2 to 3 days. Once the child tolerates that food item, only then the other should be added, and once initially started with once
No,
a day.
don't go into the details of weaning here, because the question would be explain a mother how to start weaning. So weaning, only 1 or 2 sentences is good enough. Very good. What else?
Um,
Any specialist which this child could see, this parent could see if required. So you can talk about breastfeeding counselors who are available, and you can ask them to visit them. If there is any issue with breastfeeding, always say that I will be available to help you whenever required. So you can visit us and ask if you have any doubts related to breastfeeding or related to feeding of your baby once you join work. Correct? So these few points are there which you can mention whenever this question is asked. Now, counsel an HbSAg positive mother who has just delivered a baby. Now, here there are a few points which you have to mention. Then I want one of you to attempt to do this counseling session. So what are the points that you need to mention? See, this mother is HbSAg positive. So the baby receives HbIg within 12 hours, you know that already. The first dose the baby receives of the vaccine along with hepatitis B immunoglobulin. Then the child receives vaccines at 1, 2, and 6 months. The mother is allowed to continue breastfeeding. And when the baby is 9 months old, the baby has to do an anti-HbSAg titer. If the anti-HbSAg titer is less than 10, then you have to do the HbSAg levels, because you want to show that the baby is not yet infected. So if the anti-HbSAg is less than 10 and HbSAg is negative, then you have to repeat the 3 doses of vaccine. If the anti-HbSAg is more than 10, that means the child has taken up the vaccine well and the immunity has been developed. Okay, so one of you, can you try to use these points and make a counseling session for this? Anyone? Whenever there is a just delivered mother, you have to talk about other things as well. So you have to talk about nutritional supplements, you have to talk about vaccination, you have to talk about when does the child need to follow up regularly for weight gain, height gain, for checking up milestones, and all of that also. Okay, so make an attempt, one of you, and then we'll go to the next one that will go a little faster. Anyone?
So, as the mother is HbSAg positive, I will tell the mother that there are chances of the child getting the infection during the pregnancy or during the delivery or even after the breast milk. But we have the vaccinations and immunoglobulins which can prevent that transmission or prevent the infection in the child. So that those injections we
Which
have
can
already
protect the baby, yes. Okay.
which will protect the baby. So we have will given the injection at birth and will be the child requires to be given regular vaccinations for the first month, then second and the 6th month. For this, the mother has to follow up at the clinic regularly as per the schedule for immunization, and hence the child and during all those visits, the growth of the child has to be and weight of the child has to be monitored. Mother is advised to breastfeed the child and the advantages of it to be explained.
Very good.
At 9 months, the anti-HbSAg titers would be measured for the baby, and based on that, it will decide
Correct.
whether the vaccination should be further given or not.
Very good. Excellent. So similar now, next one. This is a HIV positive mother who is due to deliver in 1 week. So how will you counsel her regarding newborn care? So all these things are same. You know the theory already. So here, what are the points which you should not forget? I've just mentioned those. Rest all, like Rutak said, we are going to talk about the same points for any mother who is going to deliver or is due to deliver. So here we will explain to the mother that we would prefer, the doctors would prefer a cesarean section, especially more important if beyond 36 weeks, the copies are more than 1,000. The baby will receive a medicine which is given orally by mouth as soon as the baby delivers. And we will have to continue this medicine for 6 weeks, which is nevirapine. At 6 weeks, you will also start with cotrimoxazole. You will explain to her that she can breastfeed the baby. However, this is dependent upon the situation that you are in. So in private practice, sometimes you give the option to the mother to decide if she wants to breastfeed or not. But you have to tell her that there should be no mixing of breastfeed and top feed. So either breastfeed or top feed, there should not be any mixing. Then you have to explain that somewhere around 4 to 6 weeks, you will be doing an HIV RNA PCR for this baby. If this HIV RNA PCR is positive at 4 to 6 weeks, you will start with full-blown ART. If it is negative, you will stop nevirapine as well as you will stop with the cotrimoxazole which you have started. You will repeat HIV RNA PCR at 4 months and you will do an ELISA at 18 months. So this is just to show the dosage of nevirapine prophylaxis that you need to give to this baby. So if the child is less than 2 kilos, it is 2 milligram per kg once a day. It is available in syrup form. And if it is a baby between 2 and 2.5 kilos, then it is 10 milligram once a day, which is 1 ml. If more than 2.5, then it is 15 milligram once a day. The dose has to be continued once a day, every day for 6 weeks. If the mother is not on any antiretroviral therapy, then you have to continue this for 12 weeks. Okay, so these are the points which should be there in your answer if there is a counseling session for HIV. Similar counseling session can also be there where you are given that the mother is a known case of tuberculous lymphadenitis, which was diagnosed in the 8th month of pregnancy. How will you counsel the mother regarding newborn care? So there are different congenital infections which you need to read up about so that you know what are the important points which you need to tell the mother to protect her child and to look after the child. Now, the next question is, this is a little, I put this simply because this time you have written OSCEs. If you have written counseling sessions, then things like this can be asked. So counsel a mother whose 1-year-old child has never been vaccinated at all. So what are the points here that you need to know? Not for telling the mother, these 4 points are for you to know because you're going to formulate in your mind the correct answer. So important is BCG and MMR cannot be given together. Can anyone tell me why is that?
Because measles will reduce the immunity of the child, and hence there will be exaggerated response to BCG.
So basically, if BCG and MMR are given together, the T cell mediated immunity is the one which is stimulated for both of these vaccines, and therefore if the T cells are stimulated for protection against one, the protection against other will be compromised. So BCG and MMR are preferably not given together. If MMR is given first, then BCG is given at least with a gap of 4 weeks after MMR. There are no such contraindications for giving 2 live vaccines together for any other vaccine. These are the only 2 live vaccines which should not be given together. Then you have different vaccines such as pneumococcal vaccine and Hib, which the schedule changes, especially if it is a catch-up immunization. The schedule changes. You should know that any number of antigens can be given on the same day. So you can have 2 intramuscular, 2 subcutaneous injections, 3 intramuscular injections, etc., given on the same day. And between 2 live vaccines, if they are not given at the same time, then the duration has to be at least 1 month. Between a live and a kill vaccine, the minimum duration, this is for catch-up vaccine, should be 15 days at least. So you have to talk to the mother about what is the importance of vaccination over here, because this mother seems to be unaware about that. So since this 1-year-old child has not received any vaccine, you have to explain to the mother why it is important to vaccinate. You have to tell her that the mother's immunity, which is there in the baby, will protect the baby only for a limited amount of time. There are very common, easily manageable side effects of vaccines. So there is nothing to be worried about giving the vaccine. And those side effects can be easily managed at home, which we will explain to you about. Then you might be asked a question, since it's a OSCE session, something like form a timetable for this 1-year-old child regards to vaccination over the next 6 months. Then you will have to make a timetable generally, what are the things you will give when. So I've just made this for this child, okay? So first visit, you will be giving MMR. This is a 1-year-old, so that becomes a priority. The first dose of MMR will be given initially. And of course, you'll be giving the 5-in-1 vaccine along with pneumococcal. You will not be giving rotavirus to this child because this child is already 1-year-old. You will be giving BCG during the second visit because you want to keep a 4-week gap between MMR and BCG. You will be giving repeating DPT and IPV as second and third doses in the next 1 month visits. Hepatitis B for catch-up immunization preferably is given at 0, 2, and 6 months, like it is given in the schedule. PCV, pneumococcal vaccine, if it is initiated within the first 6 weeks of life or at 6 weeks of life, then the doses are 3 1 month gap interval followed by a booster at 18 months. This is the IAP immunization schedule. It is different for UIP because there they give only 3 doses. Then for Hib as well, for PCV, if it is initiated after 6 months, then it is 2 + 1. If it is initiated after 1 year of life, then it is 1 + 1. And if it is initiated after 2 years of life, then there is only 1 dose. So depending upon how old this child is, the vaccination schedule for PCV and Hib will change. When there is a question like this and they have not mentioned which schedule you want to follow, you may mention the optional vaccines, but you have to write that these vaccines will be given to the child after discussion with parents. And you can mention about vaccines such as varicella, hepatitis A, typhoid. If the child is from endemic area, then Japanese encephalitis. If there is high risk, then MCV, flu vaccine, etc., which are not in the national immunization schedule, but you can mention them if you find the time, if you're asked to make a timetable. Of course, at 18 months, you'll be repeating the booster. Here you'll be giving the hepatitis B dose as well, and the second dose of varicella, which is now given 3 months after the first dose of varicella. I don't need to wait till 5 years. So I've just made a quick how, if at all this kind of question comes in the exam, you may not mention all this if it's a counseling session. For counseling sessions, you can quickly just mention the vaccines. Like, for example, we will be giving 2 doses of pneumococcal vaccine followed by a booster. That is also okay. But if you're asked to make a timetable, you have to write each and every vaccine which you will be offering to this child over the next 6 months. Coming to the next question. So counsel this mother who has a 4.5-year-old child who needs metered dose inhalers for treatment of asthma. So here you have to talk about how will you explain to the mother, how will she use the assembly at home. So please remember that mask has it can be used till 3 years. Initially, they used to say even after 3 years, the spacer also may not be required if the child is comfortable. But now with the GINA 2021 guidelines, spacer has become necessary for all at all age groups. Even for the mask, the mention is that if the child is comfortable and if the mask is well fitting, even after 3 years, you can still continue using the mask. So can anybody tell me what is the exact method of using the meter dose inhaler using mask and spacer for a child less than 5 years, under 5 years, who's a known asthma patient? Someone else now, not Pruthak. Someone else? How do you explain? In your OPD, you must be doing that.
You have to first explain to the parents, have to first shake the inhaler and
Very good.
check the whether it's working or not, and then ask the child to demonstrate in front of the child how to take few deep breaths, and then attach the inhaler with a spacer and a mask to be, and how to make a proper seal
Very
around
good.
the face area, and then press the pump, and then ask the child to breathe normally, and ask the parents simultaneously to count for 20 seconds at least, 1, 2, and loudly, so that the child also knows that he has to keep inhaling normal breaths. There's no requirement of taking deep breaths. And after that dose, if another dose has to be given, then the MDI has to be removed, shaken up again, and then again similar activity has to be repeated for the same
Yes.
for another dose. And also we have to tell the parents how to clean uh, the spacer, and this you have to just rinse it
Very
thoroughly
good.
in a running water and lay it over a dry paper towel to dry, and don't have to
Air dried. Air dried.
air
Okay.
dried, and not wipe it from inside. And have to regularly check the MDI for the number of doses left, so that if it is decreasing, they can be bought early.
Fantastic. I think you covered all the points. So only a few that you may add here is you can explain to the mother that there will be a controller and a reliever medicine. So which medicine does she have to take? That it's only the reliever medicine that she has to take for the attacks which are when they are frequent. And if the child requires reliever medicine, controller medicine, then that will be explained to her, and that can be given about 1 minute after giving the reliever medicine. It's also important to tell the parent to look at the number of doses. So, for example, an Asthalin inhaler, I'm just telling you this, you don't need to write, contains about 200 puffs. So you can say that your inhaler, don't use trade names, your inhaler usually contains about 200 puffs, and as the number of times you use the inhaler, after every 20 puffs, the mark changes. So whenever the mark reaches to about 40, then the color becomes red. So less than 40 is when the color changes to red. So you know that it is time for you very soon to buy a new inhaler. Whenever you are giving any controller medicines, you also explain to the mother that after the puff is over, the child needs to rinse his or her mouth. So these are all the things, and plus whatever you said is all perfect, very nice. Then there are other things that you need to explain, that you need to during for a counseling session like this, after you explain the method of taking the puffs. So that includes what are the red flags, when do they need to rush to the hospital. Then, of course, what are the ways they can avoid the common allergens or triggers. They have to maintain an asthma diary, and you may not talk about spirometry for small children, but for bigger children, you may talk about it. Now, I've just put this for your knowledge. This, you may not write everything in the exam, but for your knowledge, since we are discussing this, it will be easy for you to revise. So, you know, the GINA guidelines for, they have divided the age group as under 5, 6 to 11, and more than 11, or adolescent and adults as different. So if it's an under 5 visa, then you have different steps. The first step is where the child is an infrequent visa. So that's when only the reliever medicine is given. So that can be a short-acting bronchodilator, something like a levosalbutamol. If the child is a frequent wheezer, so more than 3 episodes in a year or more than 10 days the episode continues at a time, then you might have to give, along with the short-acting bronchodilator during the attack, you will also have to start on low-dose inhaled corticosteroids. The next step is when the child remains uncontrolled with low dose, you have to double the dose of the inhaled corticosteroid. And the next step is to add leukotriene is to go for specialist assessment. Please remember that leukotriene receptor antagonist, the one which we very commonly use, such as montelukast, is only a second to the first step. So that is only the second option. The best is to give the upper option for a child who is less than 5. If the child is between 6 to 11, there is no role of giving only short-acting bronchodilator at all. So if you see, even for step 1, if the child is 6 years and more, even if he is an infrequent wheezer, you will always give a low dose inhaled corticosteroid along with a short-acting bronchodilator, correct? If this child is a frequent wheezer, then you will give daily low-dose inhaled corticosteroid and you will give short-acting bronchodilator as and when required. This has to be continued for a period of 3 months at least. Then in the step 3, you have something known as MART. So that's when you will introduce low-dose inhaled corticosteroid with a long-acting bronchodilator. For example, a budesonide and formoterol combination. So if you have a budesonide formoterol combination, you can use low dose, which is 200 milligram of budesonide and 6 microgram of formoterol, which is available as a single puff. If it is a very low dose, then the dose of formoterol does not change, the dose of budesonide changes. So depending upon how comfortable you are, you may start with low dose and increase to high dose if the child is not responding when you reach step 5. So here you have to remember step 1, low dose ICS whenever the child requires short-acting bronchodilator. In step 2, low dose ICS for a good 3 months and reassess inhaled short-acting bronchodilators as and when required. So this is a little different from the under 5 wheezers. When you're talking about adults and adolescents, you know that there has to be a combination only from step 1 onwards. So here you have as and when needed combination of ICS and formoterol. This is again a type of MART. Then you have low dose maintenance of both ICS and formoterol over a period of time till the child is better, about 15 days to 1 month. You can increase the dose depending upon which step the child is and add additional agents. That's when after step 3 is when the child requires specialist attention. When you talk about red flags for asthma, you have to explain to the parent that if your child has falling saturations, that means you want to explain to the mother that the saturation has to be maintained between 93 to 96. The saturation has to be checked on hands which are not very cold and not when the child has any fever. It can be checked by multiple devices if the device reading is not coming proper. You have to explain that any presence of cyanosis or decreased number count, if there is any change in the sensorium, either the child is drowsy or extremely irritable, inability to take orally anything, passing less amount of urine. So these are all the red flags. If the child has excessive coughing and breathing difficulty, salbutamol can be given how long? Every 20 minutes at home in the form of 2 puffs or 1 puff depending upon weight of the child, which is with MDI and spacer. In 1 hour, if the child is not well, the child has to reach the hospital. After that, of course, you know what to do in the emergency department. I don't want to discuss that. So this is all important things that you need to know before you start counseling a patient who has asthma. Then we come to the next question. So counsel a mother whose 5-year-old is diagnosed with rifampicin sensitive pulmonary COX. Okay, so here you are already given the diagnosis. So you don't need to talk to the parent about how to reach to the diagnosis. The patient is the diagnosis is already given to you. So here you'll straight away start talking about how to give the medicines to the child. When should the child follow up? So when the child is on AKT, what is the protocol for follow-up? Explain to the parents what are the common side effects of medicines, which are the side effects which are alarming and red flags, and they should follow up earlier. What happens if they are non-adherent to treatment? What are the red flags during treatment? And you have to explain to them that since your child has this condition diagnosed, which is a contagious disease, we need to find where the infection came from. So investigations to find the index case. You have to talk about prophylaxis for other contacts at home who don't have active disease as well. Just for revision, I have put up this slide. So how did this child come to this diagnosis of rifampicin sensitive pulmonary coughs, right? So when this child had persistent fever or cough for more than 2 weeks, or there was any weight loss, or there was a contact with a patient who's has pulmonary tuberculosis, then you do a chest X-ray and a skin test, that is a Mantoux test, right? Now, if the chest X-ray is highly suggestive of tuberculosis, then you will do the sputum analysis or gastric aspirate, depending on how is the child able to produce sputum or not, for WRDT. This is the WHO approved rapid diagnostic test. So for example, Gene Export or CBNAT is the one that you will do for this sputum. If it is positive, then you know that this is a positive case. But if CBNAT is negative and skin test is positive, there is no other likely diagnosis, then you call it as a clinically diagnosed tuberculosis. If both are negative, then you have to suspect if you are making a wrong diagnosis or you have to refer to an expert. So can somebody tell me what is a chest X-ray which is highly suggestive of tuberculosis? What are the three things? Anyone?
Fibrocavitary lesions.
Sorry, I could not hear you. Sorry.
Fibrocavitary lesions and mediastinal lymphadenopathy.
Okay. Anything else? One more.
A visualized bond focus and halo lymph nodes.
Consolidation.
Consolidation is not. Highly suggestive means you look at this X-ray and you will know that look at this, that if the X-ray is highly suggestive, even if the gene expert is coming negative, you are diagnosing it as clinically diagnosed tuberculosis. Correct? So there are three things. Most important that all of you all forgot is miliary tuberculosis. There is no other diagnosis. Please don't forget. This is also important in your exam. If you are presenting a TB case, somebody can ask you, what are the signs on a chest X-ray which are highly suggestive of tuberculosis? So these are the three things: miliary tuberculosis, lymphadenopathy, and a chronic fibrocavitary shadow. Now, if this child has a normal chest X-ray with a positive skin test, then you have to evaluate for extrapulmonary TB, right? If the chest X-ray is normal and skin test is negative, then of course we are not worried about tuberculosis. But if the chest X-ray is showing non-specific shadows, we give a course of antibiotics and reassess after 14 days to see if the consolidation is gone. If the consolidation is still there, so there are persistent shadows, even the symptoms are still there by that time, then you have to evaluate the sputum again for gene expert. If it is positive, then you diagnose your case. So this is not for this session, this is just for your revision. So how do you reach to a diagnosis of rifampicin sensitive? This is rifampicin, so you are only doing a gene test, a gene expert. Now, if this patient has any of these 4 or 5 points, then the treatment that you start for this patient, you already know this, is 2-HRZE plus 4-HRE, correct? You may increase the continuation phase if it is a neuro or a spinal tuberculosis or a bone TB. These are the different doses of the medicines which are used in first line. Please remember that the dose of isoniazid is also now made to 10 to 15. So that is increased to be optimally effective. And the other doses are as given over here. Now, in case the patient has interrupted treatment, so you know that you tell the parent to follow up. And if you find that the patient has not been adhering to treatment well, if only 4 weeks are over, then you resume the therapy again. Within 4 weeks, if the patient has come, even if the child has forgotten to take a few medicines for a few days, you can resume the therapy again. But if it is more than 4 weeks, then you have to reinvestigate the child to see if there is any acquisition of drug-resistant TB. If rifampicin resistance is not detected at present, then you retreat with the first line 4 drugs. If rifampicin resistance is detected, then you treat as MDR-TB. Okay, so this is important when the patient has interrupted treatment. This is not for counseling. Huh? You don't need to tell the parent before only what will happen if they interrupt treatment. Just say that it is dangerous because it can lead to occurrence of resistance, and the treatment of resistant tuberculosis is longer and more difficult. So when do you ask the child to follow up? Anyone? Once you have started this child on AKT, when will the child follow up first with you?
3 weeks to check for LFT.
2 weeks.
2
1 month.
weeks. That's correct. So the first follow up is at 2 weeks. After that, once a month till the child completes treatment. And after the child completes treatment, it is every 6 months for 2 years, right? So you want to keep looking at how the child is growing and vaccinate him fully and other things after completion of treatment as well. So what are the tests that you do whenever the child is following up with you? What are the tests that you do? Do you do a chest X-ray at the end of intensive phase? Will you repeat it?
No, ma'am.
X-ray is not repeated unless there is any signs of worsening, right? Otherwise, you will just do a sputum, you will do a smear and culture, you will at the end of intensive phase to see if it has become negative. You will do a gene expert only if the smear is positive, the follow-up smear is positive, correct? You will not do a repeat MGIT culture. You will do it at the first time when you have collected the smear and sent for gene expert. At that time, you will send for culture as well. But you may not repeat the MGIT culture at all. But you will do it if the child is not responding to treatment at the end of 4 weeks of therapy. There is no role of doing any LFT during the first, when the child is on first line. You will do chest X-ray only at the end of therapy. This is very important. Okay. So this is about TB. Anything else about TB? Yeah, that's about it. So important that you send the gene expert smear culture and culture at the same time, so that you do not miss out on the culture. If you cannot start with AKT unless you have sent the culture, even if the report comes later, you have to send it at the time you send the gene. If the gene expert is positive, wait for the culture. So this is a counsel an obese child who is bullied in school. I know we are jumping from one topic to another. I hope it's not very vague in your mind. But this is another very commonly asked question. So this why I have put, because this is a counseling session for the child. It is not for the parent. Okay. So here you have to talk about in general to the child about what are the methods of how do we come to a diagnosis of obesity in this child? What are the things that they will be monitoring? What are the problems related to obesity? When will the child need to go to a dietitian? What are the various methods of treatment available? You can say that we will be talking to your parents about the different kinds of medicines which are available for treatment. It's very important not to feel that you are doing any mistake by whenever you feel like eating or whenever you are bullied in school. Please reach and the counselor or anybody who you trust. It can also be your parents or your teacher, and talk about your problems. So here you're talking about psychological assistance. Do not hesitate to ask for help. And if there are any nutritional supplements that are required, you will talk about it to the child. You may also say that I will talk to your parents about the nutritional supplements such as vitamin D supplements, which might be required for strengthening your bones, etc. Now, this is just for revision. So, what are the ways in which you treat a child with obesity? So, first stage is known as prevention plus management. Stage 2 is structured weight management. Stage 3 is comprehensive multidisciplinary intervention. So when is the first stage? When the child is more than 2 years and BMI is more than the 85th centile. Here, the child is given thorough counseling. The parents are given counseling and explained about what are the food facts that they need to follow. Explain to the parent that the child needs to be active throughout the day. This became even more important during COVID days when children were in lockdown and hardly going out and hardly having any physical activity. So over here, there is no need of doing any blood tests or any aggressive, invasive methods for control of weight. But very important to explain to the parents to not lose follow-up, because monitoring of height and weight and BMI using the age-specific growth charts becomes most important in this stage. Suppose you come to stage 2, so the child has not been responding to our management methods for 6 months after of stage 1, or the child is more than 6 years, came to you for the first time and it's already in the obese range, then you will follow stage 2. So here you'll be doing a routine set of blood tests to see if there is already any metabolic involvement, liver involvement, etc. And you will be asking the child to do structured weight management. So there'll be more rigorous monitoring, there'll be dietitian references, there may be requirement of oral medicines here as well. Stage 3 is when the child is more than 6 years with a BMI of more than 35, so more than the 95th centile already. Then you will require a multidisciplinary approach for management, and here you may give the parents the possible requirement of medical and surgical intervention if required, if the obesity is not coming under control in the period of 3 to 6 months. Different kinds of exercises are there which you can talk to the parents about. So you can see this when you're seeing the recording in case, so you'll be able to get a little better idea about what is exercise. Now, the mother who's diagnosed to have the first episode of nephrotic syndrome. Again, we are jumping. I don't know, I didn't realize when I was making this PPT, but I think just jumping. If there is any doubt, please tell me, we can go a little slow. So, what is nephrotic syndrome? You need to tell the parent here. What tests need to be done at the onset? What is the form of treatment? Is there any specific nutrition advice that you will give? How will the child be monitored at home? What are the red flags? When will the child follow up? Is there any specific vaccination? And what is the prognosis? So can somebody tell me, okay, I've already put this. What is nephrotic syndrome? So heavy proteinuria, hypoalbuminemia, presence of edema, and dyslipidemia. This is the definition of nephrotic syndrome. So how will you explain to the parent? Can anybody make an attempt? If you have heard Ambekar sir talking about nephrotic syndrome, I'm sure you'll be able to do it. How will you tell them what exactly is happening? Someone please try.
There is loss of protein from the kidneys, so the filtering capacity of the kidneys is affected, which causes the loss of protein, and because of that, there is retention of the salt and water retention, causing edema, causing the presentation as edema in the child, and yeah.
Correct. Very good. So also just to add, Ambekar sir always mentions this, that the kidney is like a sieve, you know, like how you sieve your milk or anything. So in nephrotic syndrome, what happens is the holes of this sieve become a little bigger. So you can actually demonstrate it with your fingers. And because the holes become bigger, there is chance of bigger molecules such as proteins, to which are usually otherwise filtered, cannot be filtered, and they pass down into the urine. So protein is lost, and because of protein loss, there is hypoalbuminemia, which causes all the signs and symptoms of nephrotic syndrome. Correct? So that is one thing. What is nephrotic syndrome? When you are telling the parent, how will you explain? Now, at the onset, you need to do a set of tests once you have almost confirmed the diagnosis before starting the treatment. So here you have urine routine, CBC, urea creatinine, electrolytes, total protein, albumin, total cholesterol, and a MAN2 test. So these are the tests that we need to do for your child before we start treatment. Once we confirm that all these tests are normal, then we will be starting with treatment. So can somebody tell me what is the treatment of nephrotic syndrome?
Continuous day steroid 2 mg per kg for 6 weeks, followed by 1.5 mg per kg alternate day for another 6 weeks.
Excellent. So that is the treatment for nephrotic syndrome. Plus, when this treatment is going on, you have to explain to the parents that they need to monitor the child's urine output at home. They have to monitor the urine dipstick. You have to explain to them what the dipstick looks like. So the bottle has to be tightly sealed. The bottle, once it's open, you have to remove only one stick and seal the bottle again. The urine which is immediately collected, the strip needs to be dipped in the urine as soon as possible. Once it's removed, the extra urine should be tapped off, and then after 1 full minute, the color change on the strip has to be checked with the color monitor, which is given on the box of the strip in which the strip is present. That is the only way you can find out how much protein is getting excreted every day in the urine sample. Now, only when the parent is able to do this, you can tell them about relapse. So anything more than 3+ on the dipstick for 3 consecutive days is a relapse. You know that. So once you explain to the parent, they have to come back to the hospital in case after remission, there is any evidence of more than 3+ in the dipstick for 3 consecutive days. Generally, 80% of children achieve remission by the 2nd week. So don't be alarmed if the remission is not achieved by the end of 1 week. By 2 weeks, generally, the child starts decreasing the urine protein that was there initially. And then it goes on decreasing as the treatment continues. Now, during remission, they are advised to screen for proteinuria 2 to 3 times a week. The child should be continuously monitored for presence of infections and presence of edema. So these are the definitions of nephrotic syndrome. These are given in all your books. Over here, what are the important ones are remission, relapse, steroid dependence, and steroid resistance. Okay, so in steroid resistance, what does it say? Lack of complete remission despite therapy for 6 weeks, which means that you keep on giving the medicine once a day for 6 weeks, even if the child does not achieve remission, to say that, okay, now this child falls into steroid resistant nephrotic syndrome. Correct? And steroid dependence is when 2 consecutive relapses are happening when the child is now put on alternate day steroids or within 14 days of its discontinuation. For vaccination, what is important is the second point. If the child has received high dose prednisolone for more than 14 days, which obviously our child will receive, then you vaccinate after 1 month. If the child has received other immunosuppressants such as cyclophosphamide, it is 3 months. Then there is levamisole or mycophenolate mofetil, it is 1 month. And therefore, you have different kinds of delay that you need to follow between the vaccinations that are due if this child is on any kind of immunosuppressive therapy. What are the red flags that you will explain to the parent about? So fever, breathing difficulty, abdominal pain, headache, convulsions, loose stool. So these are all the signs suggestive of the red flags which you see in nephrotic syndrome, such as subacute bacterial peritonitis, or there is presence of acute gastroenteritis, there is presence of infection, there is presence of nephritic with nephrotic syndrome, etc. So these are the different red flags that you need to talk to the parents about, and they need to follow up with you immediately. Okay, I had put one more slide here, which I think got missing. So you have to explain also to the parents about the child needs to continue with all the regular activities, even if he is on the steroid treatment. He needs to have a diet which is not very high in added salts. There is no need to decrease the amount of water intake unless there is very severe edema. They can have increased protein containing food. So these are the things that you need to explain when you're talking about nutrition. So these are the ones which I have covered. Of course, there are many other topics, but in 1 hour, I thought we could cover only these. If there is still any doubt or there is any assistance that you need for OSCEs in counseling, please put up on the group so that we can arrange for more sessions with other doctors and other teachers also. If there are any specific counseling sessions that you're worried about, you can put those to me as well, so we can prepare a new slide. We can have a new session with extra counseling sessions that you can discuss as well. I hope sincerely that this was useful for you. See, these are counseling sessions, so I will not be teaching you anything. It's just like a revision. You need to know your topic before you start counseling the mother. So that's what I've tried to do in this presentation.
Ma'am?
Yes, sorry.
Ma'am, so if we have been asked to talk to the patient like we are doing it in hospital, so should we do it in English or local language, or how should we in exam?
Whichever is fine, because just make sure that the examiner understands your language. That is more important. Okay. Whichever language you're comfortable. You can say that I would prefer to talk to you in the language of your choice. So don't wait for the examiner to say, okay, go ahead, talk in Hindi. Just keep talking one after the other. But like I said, this December, it may not be like that. You might have to just write the important points. Just keep a track of the messages which come from the DND board so that you're more aware of exactly how the sessions are going to be. But from what I have heard, they are going to be the COVID protocol, the COVID time, how they did the virtual OSCEs, they're going to be like that. So you may have to just write down the important points. So that's why when you're writing down what I put up already, only the important points you write first, the remaining points which may be common for other topics, you can write in the end if you have the time. So that you don't miss the important points. Okay?
Okay.
So thank you very much, all of you for joining, and we'll see you next week. I think Shokhani sir will be taking a talk on next Saturday. Thank you very much.
Thank you.